Jennifer Larson. She will talk on eye surgeons, the next generation. I wanted to give a brief introduction first. Next slide, please. Dr. Larson has a distinguished educational history. She received a Bachelor of Science with honors at Marquette University. She received her medical degree here at University of Wisconsin in Madison at the School of Medicine and Public Health, and remained with us for her ophthalmology residency from 2014 to 2018. And she was our selected chief resident for her senior year as our chief resident. Next slide, please. Currently, Dr. Larson is an assistant professor in our department here at UW-Madison. And she also serves as the fourth-year ophthalmology clerkship medical student director and has done so since 2018. Dr. Larson has multiple awards as well as presentations and published manuscripts. And I am pleased to introduce her tonight. Again, her talk is on eye surgeons, the next generation. Thank you.
Thank you. We'll go ahead and get started. So thank you for that warm introduction, Dr. Young, and thank you everyone for participating in this presentation tonight. I'm very excited about what we're going to be talking about. We're going to be focusing on how do we train the next generation of eye surgeons. So the objectives for our talk will be to review the current curriculum we have to train surgeons in training here at UW. We'll then review the surgical outcomes of procedures completed by resident surgeons. And lastly, but most importantly, we're going to highlight the invaluable role that patients provide to support our surgeons in training. So the outline of today's talk, first we'll start by overviewing what is ophthalmology residency, and then we're going to focus the majority of the talk on cataract surgery. We'll briefly also discuss subspecialty surgeries, and this will be followed by reviewing the surgical outcomes. And lastly, we'll have a patient and resident testimony. I have no financial disclosures. So let's start with what is ophthalmology residency? So to become a resident, residents are actually fully licensed physicians, and they are individuals who have completed an undergraduate training and also have completed medical school. Residents are in training that is supervised by the ACGME, which is the Accreditation Council for Graduate Medical Education. And this council is the nonprofit organization led by physicians that is setting and monitoring the professional education standards that are needed to prepare the physicians to deliver safe and high quality care throughout our country. This organization also defines the core competencies and milestones and establishes the minimum case numbers that trainees must attain to become competent and to graduate. Now, after residency, residents, when they graduate, can either go on to practice medicine in whatever specialty they went into, or they can go on to do fellowship training to subspecialize in their particular specialty. And an interesting statistic is 1 out of every 7 active physicians in the United States is a resident or a fellow. Ophthalmology residency in particular is a 4-year training program. The first year, or PGY 1 year, which is postgraduate year 1, is what we call a transitional year. That's where residents complete 3 months of ophthalmology specific rotations, but the rest of the year they're completing internal medicine rotations and doing other medical electives. The second, third, and fourth year of ophthalmology residency is with ophthalmology specific rotations only. And now we'll shift gears and talk about cataract surgery. And we're going to spend the most of the time talking about cataract surgery because cataracts are incredibly prevalent. Approximately 24.5 million Americans have cataracts, and the National Eye Institute estimates that 50 million Americans will be affected by cataracts by the year 2050. By the age of 75, approximately half of Americans are affected by cataracts. And cataract surgery alone remains the most effective way to help restore vision for those with cataracts. Approximately 2 million cataract surgeries are performed in the United States each year. And cataract surgery is the most common surgical procedure completed by ophthalmologists. And it's also one of the most commonly performed surgical procedures overall. The benefits of cataract surgery include a 40% lower mortality risk for our patients, 16% decrease in the odds of a hip fracture, and a 13% decrease in the odds of a car accident. So given the prevalence of cataracts and cataract surgery, it's no wonder that cataract surgery is an integral component of ophthalmology residency training. And we have to have our novice surgeons build their confidence and their skills in the operating room, but we have to do this without compromising patient outcomes. Approximately 21 to 39% of cataract surgeries are completed by residents in the developed countries, and the learning curve for the surgery is quite steep. So the ACGME does require 86 cases to be completed by a resident for them to graduate and to be considered competent. However, the national average is well above this, with around roughly 200 cataracts completed by residents prior to them graduating. At UW, our residents typically graduate with 200 to 245 cases. There are 7 basic steps of cataract surgery that the residents must become proficient at. The first step is creating the wound or the incisions of the eye. The second step is actually opening up the cataract. And if you think of the cataract like an M&M, you can think of it like having a candy shell and having this chocolate center. So capsulorhexis is opening up that candy shell of the cataract so that we can now take out the cataract itself, or that chocolatey layer of the M&M. So once the capsulorhexis is completed and the cataract is open, we then do hydrodissection. And that's creating a fluid wave between the capsule, or that candy shell, and the chocolatey layers of the cataract. The next step is to do sculpting, where we actually are breaking up the cataract, or that chocolatey layer of the M&M, into small little pieces. And then quadrant removal is removing those pieces one at a time. This is followed by cortex removal, which is cleaning up that candy shell, or that capsule of the cataract. And then lastly, we have to put in an intraocular lens in at the completion of the case. So again, our resident surgeons need to become proficient in all of those steps of the surgery. So how do we teach them to do this surgery? Well, there's 4 components that are really the cores of our cataract curriculum. The first is just didactics, or lectures. The second is simulation-based training. The third is the teaching we do in the operating room. And the fourth is the feedback that we provide. So let's start with didactics. So all of the residents are assigned different readings based on their level of training. Our second-year residents, we're having them read to focus mostly on how to do preoperative and postoperative management. What are the components of informed consent? What are the surgical risks assessment that's needed? And how to properly select the power of the intraocular lens that the patient requires, and what are the formulas and measurements that are needed to do so. Our third-year residents are focusing on the basic phacoemulsification, and what that means is just what are the principles that go into the actual steps of cataract surgery. And the fourth-year residents are focusing on advanced phacoemulsification. So maybe what are some complications that can happen during cataract surgery, and how do we address them? These residents do receive lectures on these topics as well as assigned readings, and they do have pre and post knowledge assessments throughout the year as well. So now let's shift gear and talk about the simulation-based training that we have available. So in the literature, there have been seen to have high complication rates when residents start operating early in their training, early when they're starting to do cases. It's been shown that they have higher complications compared to when they are more proficient in the operating room. But it's been shown that if you implement a simulation-based training program, we can decrease those complication rates that were initially seen in that earlier transition period when residents are starting to operate in the operating room. Specifically, the University of Iowa saw their complication rates decrease by 50% once they implemented a structured simulation-based training program. A survey of residents found that they feel more comfortable and prepared for the steps of cataract surgery when doing simulation-based training compared to didactics. Both of this is showing, again, the importance of this model of teaching. There are lots of different resources available to do simulation-based training, and a comprehensive review is actually available on our Academy's website, the American Academy of Ophthalmology. But what I really want to highlight is these tools and these different resources are not just for residents. Practicing ophthalmologists can also learn new procedures or refine their own surgical skill using the simulation-based training that is available. And so the lessons that we're teaching our residents in the wet lab and with our surgical simulators actually will serve as a foundation for their surgical career, as well as teaching them to get prepared to help assist us in the operating room. So the first simulator that I want to talk about is the EyeSi surgical simulator. This is a computer head that has a mannequin eye and virtual eye. It has 2 foot pedals, one to control the microscope and one to control the cataract machine or the phacoemulsification machine. It also has this operating microscope that produces a 3D image, and you can see what the resident is doing on a TV screen that's adjacent to it. So this surgical simulator provides training-based modules and allows residents to practice and receive feedback on appropriate surgical techniques. Construct validity has been demonstrated for this technology, and each resident is given a personal account. And so the software in this simulator requires that a resident passes a step before they're allowed to advance to a next step, making them become competent before they're allowed to learn a new step. The simulator is broken into 4 different modules. Cat A is the introductory cataract course, and this course focuses on safe instrument handling. This includes learning proper machine settings and proper tissue treatment. It also has modules to practice anti-tremor training and bimanual navigation, or how do you use both hands in the eye at the same time. And it introduces the basic concepts to capsulorhexis and to phacoemulsification. Cat B is the beginning courses of cataract surgery. Cat C are the intermediate courses, and Cat D are the advanced courses. Now, after a resident has worked for 60 minutes with a simulator, they are given a cataract challenge where they are able to do a complete cataract case from the front to the end. And the goal is to score high on those cases to show proficiency in cataract surgery. Now, if we look over here, this is sort of what it would be like with the different modules for training with a simulator. So Cat A is going to be practicing, again, safe instrument handling, anti-tremor, bimanual navigation. And to have that simulate for a capsulorhexis, the skill that might be asked to be required would be to push this little ball in a circle in the anterior chamber or in the front part of the eye. Again, getting used to that movement with your hands of going in a circle. Cat D will be the beginning courses of cataract surgery. So that will be asking the resident to perform a capsulorhexis, but it'll be giving the outline of where the tears should be on that capsule. Cat C will be without any guidance, and they'll be expected to know how to tear for a capsulorhexis. And then Cat D will be if there would be like complications at the time of doing a capsulorhexis. So this might mean that the capsule is really brittle and it tears easily, or maybe it's really hard and it's hard to tear it and you have to maybe cut it, or maybe the zonules or the little arms that hold the lens in place are weak and the lens is moving while you're trying to tear it. So it has this progression of skill set, which is a great way for the residents to learn the surgery. The benefits of the simulator is that it allows the practice of specific skills and surgical techniques, and specifically it allows for this repetitive practice. The simulator demonstrates the areas of surgical weakness by providing instant feedback. And by doing so, it helps also increase surgical confidence. And it's been shown that the less adept residents benefit the most from this training. Overall, the simulator helps shorten the learning curve for surgery. It improves hand-eye coordination and improves surgical techniques, which all translates in the operating room to reduce surgical time, reducing the need for attending intervention during the resident surgery, and resulting in fewer complications. A study that looked at the complication rates for residents who were trained on the EyeSi simulator to those who were not trained on this EyeSi simulator showed that the complication rates were significantly decreased in the group of residents who were trained with a simulator. So this is the group of our simulator-based residents and our not simulator trained residents. And you can see their overall number of surgeries was roughly equivalent, but the complication rate was less than half in those residents who were trained with a simulator. The same study found that 91% of residents who were trained with a simulator thought the training was extremely worthwhile. So our UW Cataract curriculum asks that residents in their PGY2 year or their second year that they dedicate at least 1 hour per month with the EyeSi surgical simulator. There are 2 dedicated teaching sessions with attendings during this year as well. Our third year residents are asked to dedicate 1 hour for their first 6 months, and then there's self-directed learning after that. And there's 1 dedicated teaching session for these residents with an attending, and that's a session that I'm fortunate to participate with our residents. Our fourth year residents are then asked to do more self-directed learning, and additional attending sessions can happen as requested. So let's watch a video of one of our residents using the EyeSi surgical simulator and what that looks like. So here he is doing a bimanual navigation. And so this module is trying to get used to using both instruments at the same time in the eye. And he is trying to get the instrument in those little balls to turn them green. And now he's using the simulator to create a capsulorhexis. And this is that Cat B training, where there's the beginning phases of the cataract surgery being taught. So you can see the outline of where he's supposed to be tearing for cataract surgery. And now he's using phacoemulsification to actually break up that lens or that cataract. So it's just a great technology that we're fortunate to have here to help teach our residents. So let's shift our gears now and focus on the Wetlab teaching that we do. So our curriculum for the Wetlab is focused predominantly for our PGY2 residents. And initially, we're teaching them how to learn the basics of the microscope, the surgical instruments, including the foot pedals that are used at the time of surgery and the phacoemulsification machine itself. They're asked to learn how to properly fold and insert intraocular lenses, which is seen here in this picture. That's what eventually gets implanted at the time of cataract surgery. They're asked to learn how to properly construct wounds and suture, and then do the steps of cataract surgery, such as capsulorhexis and phacoemulsification. And eventually, they will be doing complete cataract cases. Throughout the year, these residents have dedicated teaching sessions with attending surgeons. In the Wetlab, we have a variety of resources that we can use to teach. We can use pig eyes, human cadaver eyes, and synthetic eyes. Our pig eyes come from South Dakota, and they are readily available. These are great for completing cataract cases, for doing suturing practice, and more, such as eye trauma. However, as you can imagine, the eye tissue of a pig is different than the eye tissue of a human. And so the differences of the anatomy and the tissues can make the surgery and the techniques different than what's actually what the actual experience would be like in the operating room. And that difference is why these human cadaver eyes are so great. Now, these eyes come from the Miami-Dade Lions Eye Bank. And because of that, though, supply may be limited. These cases, though, are great for cataract surgeries, for suturing practice, and more, with the exception that the eyes may be pseudophakic, meaning that they've already had cataract surgery. But the tissue and the anatomy is ideal, especially for suturing practice and for wound construction. But they also now have synthetic eyes that we can use in the wet lab. So the first synthetic eye that I'm aware of that came to the market is what we predominantly use in our own wet lab. It's made by Cadaver. And these Cadaver eyes allow residents to practice certain steps of the surgery, such as just the capsulorhexis, but also to do complete cases from the start to the finish. And so let's watch a video of Dr. Wingelar, one of our residents, doing cataract surgery on a Cadaver eye. Now, I must apologize. We don't have a way to have video recording in our wet lab, so the video is a little jumpy. So here, he's opening up the capsulorhexis. So opening up that candy shell of the cataract. And then is going to use this cataract machine or phacoemulsification machine to first sculpt the cataract into small little pieces, which he will then remove one at a time, which he's doing right now. And then lastly, we put the intraocular lens in, and it's unfolding inside the eye. A different brand of synthetic eyes is the Philips Studio eyes. These are a little bit newer to the market, but they're great for doing just routine cataract cases. But there are also different modules for doing different surgical techniques, such as small irises, and how do you deal with that at the time of surgery. Further, like even advanced cataracts, you can have different modules to learn and practice different surgical techniques. So let's watch a video about cataract surgery with one of these Philips eyes. And this video is shared by our colleagues at the University of Iowa by Dr. Oding. And it's a video of one of their residents doing cataract surgery on the synthetic eye. So here the resident is making the main incision, filling the eye with viscoelastic, which is the jelly to keep the eye firm and filled for surgery, making a side incision. And now the resident is doing the capsulorhexis, or opening up the cataract. Again, that candy shell. And once that's completed, there's a gentle hydrodissection to break up the cataract from the candy shell or the capsule. And now using the phacoemulsification machine to start to thin out the cataract and to break it into small pieces. Now, they are practicing a different technique called stop and chop. So they're going to break the cataract up into two halves, and then they're going to use the second instrument to chop the big half into two smaller little pieces. So there's a couple different ways to break the cataract up into small pieces. Typically, we use divide and conquer here at UW, but this is just a different way called chopping. So here he's taking one big piece and chopping it into two smaller pieces. I'm going to do the same thing on this other half, taking one big piece and chopping it into two smaller pieces. And the smaller pieces are then just easier to be removed. So now that's what he's doing, is removing those pieces from the eye. So Bionico is another company that's a little bit newer to the market that also produces synthetic eyes. And this company also has models of synthetic eyes that can be tailored to specific surgical techniques that are trying to be taught. And so let's watch a video of one of these synthetic eyes. So this is creating the capsulorhexis, or that opening on the cataract, hydrodissection, phacoemulsification, so thinning out that cataract and breaking it into small little pieces, taking those pieces out one at a time. Putting in the intraocular lens, suturing the wound and practicing suturing. Okay, and then the last synthetic model that I want to mention is the simuli eyes. These eyes likewise are a little bit newer, but they also can be very tailored for the specific skill that you want to teach in the wet lab. So you can have models just to practice the capsulorhexis, models to practice how to manage a small pupil in the operating room, models to do iris suturing and iris fixation, and models to practice how to manage an anterior vitrectomy. So if the jelly in the back of the eye comes forward during cataract surgery, that has to be removed with an anterior vitrectomy. And there's models that are allowed, that are available to practice that surgical technique. So this is a video of the model with a small pupil and putting a device in during surgery to help expand the pupil so the cataract can be safely removed. So this is called a Malyugin ring. It's mechanically dilates or expands the pupil so that the pupil stays wide enough for the surgery so the cataract can be taken out. And now that device is being removed. So there's a lot of great different models available to practice these different advanced surgical techniques. I can't talk about simulated based training though without mentioning the Midwest Phacoemulsification course. This course is truly amazing. It's been in running for the past 22 years, and it's a combined effort of the University of Wisconsin, the University of Iowa, the Medical College of Wisconsin, the University of Nebraska, and the University of Kansas. In addition, many veterinary schools throughout the country also participate. And the first day of this course, which is an annual event, is filled with just lectures. And so that's on a Friday. And the second year residents are getting lectures about the basics of phacoemulsification. Our third and fourth year residents, though, are learning about advanced surgical topics, such as what do you do if there's a small pupil or a complication like an anterior vitrectomy that's needed. The second day of this course is the wet lab, and this is like Christmas for all of us. It's a great day to be an educator. And so we spend Saturday in the wet lab where the second and third year residents are learning the steps of cataract surgery, or performing the steps of cataract surgery, I should say. So there would be 7 different stations, and at each station, they're doing a different step of cataract surgery. Our fourth year residents, though, are learning the advanced surgical skills, such as how to put in that Malyugin ring that we just saw a video of, or how to do an anterior vitrectomy, like if there would be a complication. So this is just a great resource that we have to help teach our residents. And now let's shift gears and talk about how do we teach residents in the operating room. So there are a couple of different teaching methods that that different attendings use for surgical teaching of residents in the operating room. The first is sequential training, where the residents are asked to perform the surgical steps of the cataract surgery in their routine order, so from front to back. There's also reverse training, where the residents learn the steps at the end of the case first, and then progressively learn the steps at the beginning of the case. There's module training, where the resident performs the same one step over and over until they are competent at that step. And then there's time-based training, where the resident surgeon does as much as possible within a set dedicated amount of time. There's no real data on which method is the most effective for teaching, but at UW, we tend to teach using the reverse training method. A lot of the teaching that happens in the operating room actually occurs behind the scene, though, with the attending being able to discriminate cases that may be considered low risk versus cases that are considered high risk. And with that, which cases would be appropriate for the surgical level and surgical skill of the residents. So our low risk patients, or low surgical risk patients, are those who are healthy, who have good dilation, a moderate cataract grade, with clear corneas, average eye measurements, no history of previous eye trauma or eye surgeries, and no eye conditions or medical conditions that may predispose to complications during surgery, such as pseudoexfoliation or the use of a medication like an alpha antagonist. These low risk cases are great for our PGY3 residents and early PGY4 residents. Now, the higher surgical risk cases are those cases with dense cataracts or poor red reflexes due to maybe blood in the back of the eye or a mature lens. Those that might have zonule weaknesses, again, those little zonules are the arms that hold the lens in place. And if they're weak at the time of surgery, that lens may be predisposed to falling towards the back of the eye. Patients that are older or history of previous eye surgeries are also considered higher risk, as are those with the smaller pupils. And these cases are typically reserved for our more advanced fourth-year residents who already have a solid surgical foundation. We also, as attendings, have to pick the proper type of anesthesia for our patients. Most cataract surgeries are completed with topical sedation, meaning patients are awake, but you can also use monitored anesthesia care, which is with an anesthesiologist, and patients are still awake with monitored anesthesia care, but they can be perhaps a little bit more sleepy, which can sometimes lead them to be a little bit more comfortable. This monitored anesthesia care is sometimes combined with a retrobulbar block, where an injection is actually given behind the eye to numb the eye muscles so the eye doesn't move at the time of surgery, and it also enhances comfort during the surgery as well. And lastly, surgery can be done with general anesthesia, where the patient is fully intubated and sedated. Now, picking the type of sedation may be largely, of course, related to what the patient requires, but also based on surgical skill of the residents. So at our VA hospital, frequently the veterans undergo MAC with a retrobulbar block for surgery because the residents' cases may take a little bit longer. We want to ensure patient comfort during those surgeries. That type of anesthesia with a retrobulbar block is also used for possibly more complicated cases of cataract surgery that may take longer, such as extracapsular cataract surgery, which is what we did in India. And this is what this picture is showing, is when we went to India to learn that surgical technique. In the operating room, attendings have to define also when should we intervene if things aren't going well. And this is truly at the discretion of the attending surgeon who is present. Although we tend to have sort of hard stops or things we look for when we would take over. So if the capsular rhexis tends to go wide, or if the resident is unable to rotate the lens after hydrodissection, if the surgery is taking a long time, or the resident struggling taking out the pieces of the cataract, or if there are any unexpected complications or challenges, the attending surgeon will take over. In our curriculum here at UW, we favor, again, this reverse training teaching method, where we teach the end steps of the cataract surgery and then progressively teach the beginning steps. And the advantage to this is that the final steps of the cataract surgery are manually simpler to complete. And if a complication would occur later in the surgery, it's typically less visually significant and easier to correct. So our second year residents, they're learning these lower risk steps, which might involve suturing, taking out the viscoelastic or the jelly, putting in an intraocular lens, or removing the cortex. Our third year residents are now starting to learn those higher risk steps, such as taking out pieces of the cataract, sculpting the cataract or breaking it into small pieces, opening up the cataract with the rhexis, or even creating the incisions. They eventually will be doing full cataract cases, but typically on those lower surgical risk patients. Our fourth year residents will be doing full cases predominantly, first with the more straightforward lower risk, but then also doing higher risk cases. They also will be learning different ways to do cataract surgery, such as the femtosecond laser assisted cataract surgery, where we use a laser to help with certain parts of the surgery, and doing extracapsular cataract surgery, where we go to India to learn this technique. And this is when I actually went to India with my colleagues to learn that. So let's watch a video of cataract surgery, what it might look like with the attending teaching. And I apologize if the sound doesn't work. I'll just narrate these videos. But over here is a video of me doing surgery with Dr. Winglar and then watching what he's doing under the microscope.
So we're going to get started. I already made the first incision. Can tell it doesn't
So the
hurt.
first incision's made and the numbing medicine is given.
Cold or warm as it enters the eye. This will keep you comfortable throughout the surgery though. You're going to put a little jelly in your eye.
And now we're inserting viscoelastic. This viscoelastic just helps hold the eye still for the surgery. Now the main wound is being created.
Next, we're going to
The cataract is now being opened with that
cataract is like
capsulorhexis.
peeling the candy shell off of an M&M. So it's pretty delicate. So just do your best to look at those 3 white lights. We're going to help hold your eye where it needs to be. You're doing a perfect job.
And once that step is done, then we do hydrodissection, which is breaking up or loosening up the capsule and the nucleus, or the bulk of the cataract.
Start to blur the vision a little. That's
now using phacoemulsification to start to sculpt the cataract, to break it into small little pieces.
That machine is kind of like an eyeball vacuum cleaner. It's going to break this cataract up into small little pieces. To do so, it uses a lot of water, so you're going to feel lots of water, maybe a little pressure. Mostly you're going to hear some kind of funny noises, and that's the ultrasound power working to break your cataract up. This is going to be the longest part of the surgery. You're doing a great job holding nice and still. The funny noises is taking those pieces out one at a time.
And once the cataract is broken into those smaller pieces, then they can be taken out safely one at a time.
Everything's going great. The second piece is coming out. So the cataract's almost halfway out. Everything's going exactly as planned. Do the last piece coming out. Everything's looking great here.
So the final pieces of the cataract are coming out. And then we do cortex removal, where we're going to take out the little, what we call kind of crumbs or cortex of the cataract. And this is just to keep that candy shell all polished and clear, so the new intraocular lens can be inserted into the eye.
Next, what we're going to do is put some jelly in your eye, and that will help keep that candy shell in place so that can be ready for your new lens to go in. Good. And then here's the coolest part.
And then the intraocular lens is being inserted.
It's going to be folded, and when it unfolds, it's going to catch the light.
And this is what's going to provide kind of like that glasses prescription for patients. And now they're just cleaning out the jelly in the eye that was put in at the time of surgery. I'm just going to check those incisions and check the eye pressure.
Incision looks perfect. Pressure feels great. But we are all done with cataract surgery.
Good. And then that was a completed case by a resident, which went just perfectly. So the last, but definitely not the least, core component of our UW Cataract curriculum is with feedback. So we provide verbal feedback during and at the end of every case and simulated teaching session. And we also do surgical reviews with our residents, where we record videos during the operating room and then review them afterwards to talk about things that went well or maybe things that didn't go well. Residents are also asked to keep a teaching log where they have to write basically a diary of the different steps of the cataract surgery and all the nuances that occur with it. They also are asked to keep a surgical log or a running log of all the cases that they perform. And there are also the ACGME milestones, which must be met to ensure the competency of cataract surgery is achieved. So this is an example of the surgical log. This is actually my surgical log when I was a resident. And this is what you want to see. So the beige color is practice in either like the wet lab or in the EyeSi. Green is the resident actually completing different parts of the surgery. And yellow is when they're watching the attending do the surgery. So this is showing, again, that reverse training teaching method that we use, where typically the last parts of the cataract surgery are learned first. So just intraocular lens insertion, but the resident is spending a lot of time in the simulated based training sessions. And this is when the resident's getting a little bit more proficient in the operating room, starting to do more steps of the cataract surgery, but still watching lots of the surgery being done by the attending. And this is when, you know, I was starting to do more parts of the surgery, kind of more complete cases, but every now and then the attending would still have to intervene to help me complete that step, which is what the red is. And excuse me, at the end of the case, this is, or prior to graduation, this is what we are hoping residents will all have is that they're able to do full cases from the front to the back without any intervention from the attendings. I'm so sorry, my throat. Okay. I'm losing my voice if you can't tell. So again, prior to graduation, this is what we would expect our residents to be able to have is complete cases with no complications, doing all the steps proficiently of cataract surgery. And what's great with this log is that residents leave comments for each of the cases, and so do the attendings. And so you can write down what went well, what didn't go well, and all the attendings have access to this log. So prior to the resident working with a particular attending, the attending can see what the resident is doing well or maybe is struggling with, and so they can tailor their own surgical teaching in the operating room to that feedback. And then for the ACGME milestones, so we know that just achieving a minimum number of a procedure does not define competency for that procedure. So just because a resident gets 86 cases of cataract surgery, which is the minimum needed to graduate, that doesn't mean that they're competent at cataract surgery. So these milestones were created to help ensure that competency is achieved prior to graduation. And these milestones are used by residency programs for semi-annual review of the residents. And then this is reported back to the ACGME for monitoring. And these milestones exist for each of the core competencies defined by the ACGME. And this just happens to be the milestones that were established for cataract surgery. They're arranged into different levels, from level 1 being novice to level 5 being expert, with the level 4 being the graduation goal. So let's shift gears a little bit and now briefly talk about subspecialty surgery. So the subspecialties within ophthalmology that do surgery include pediatrics and strabismus, oculoplastics, glaucoma, cornea, and retina. And all of these subspecialty surgeries follow that same sort of algorithm of how to teach surgery that was outlined for cataract surgery. And that includes the didactic sessions, the simulation-based training, and also, of course, the teaching in the operating room. So the simulation-based training that exists for some of our subspecialty surgeries include a laser course, an eye trauma or open globe course, extracapsular cataract surgery course, a glaucoma tube shunt where residents learn how to put in devices to help lower the eye pressure, an oculoplastics course where residents learn how to do basic eyelid procedures such as repair of like lacerations. And that EyeSi surgical simulator actually has the tools to do vitreoretinal surgery, such as how to repair a retina detachment. And then, of course, residents and fellows are trained in the operating room on these subspecialty surgeries as well. But some of the training may be directed more towards fellows, and that's why residents may do a fellowship, is to learn those particular surgical procedures or become masterful with those by completing a fellowship. So let's now look at the literature at the resident performed outcomes of a cataract surgery. So in the literature, the complication rates for resident performed surgery can vary anywhere from 2% all the way up to 14%. And the complication rates have been shown to decline after an average of about 70 cases. That's sort of where we see that plateau in surgical complications. However, it's about 96% of cases without ocular comorbidities. Patients end up achieving a final visual acuity of about 20/40 or better, which is great when residents do their surgeries. So there was a large study of almost 9,000 cataract surgeries that was reviewed. Residents were involved in about 44% of those surgeries, and 80% of those resident surgeries were done only by the resident, and the rest were done in combination of the resident and the attending. And 70% of those cases were defined as simple or low risk surgical risk, where 33% were defined as high surgical risk. The overall complication rate in the study was 2.7%, with simple cases having a lower complication rate of 1.8%, and the complicated cases having a higher complication rate of 4.3%. Now, a greater proportion of the complex or high-risk cases were completed by staff. So this paper decided only to look at outcomes for those that were done by the simple cases. And looking at the simple cases alone, there's no difference in the complication rate or the posterior rupture rate or vitreous loss rate when the surgery was done between residents or the staff surgeons. And this is consistent with previously published studies showing that low complication rates are achievable through appropriate case selection and meticulous supervision by the attending surgeons, and that resident involvement in cataract surgery in an academic setting is safe and doesn't place patients at an increased intraoperative risk. Another study of about 1,300 resident-performed cataract surgeries showed that visual acuity does improve significantly in patients after cataract surgery, and this visual outcome, though, was slightly worse for the fourth-year residents as a result of their increased case complexity and patient comorbidities. But the complication rates were similar between levels of training, and the surgical time did decrease, though, for each year of training, which makes sense as residents become more proficient. A different study of around 6,000 resident-performed cataract surgeries showed that 54 patients, or less than 1%, required a trip back to the operating room within 30 days. The most common reason for reoperation was a retained lens fragment, but this overall was a very low rate for reoperation of resident cases. And by resident level, the reoperation rate didn't change for the level of resident training. And despite the reoperation that these patients did have, most patients did achieve a great visual outcome, with almost 80% having vision better than 20/40 at 1 year. And looking at cataract surgeries that were considered complicated because of iris challenges, either small pupil or pupil coming out or prolapsing at the time of surgery, this compared these cases to that were done by residents or attendings, and it showed that the cases took longer for residents to complete, but there was similar visual outcome and no difference in complications or adverse events if the case was done by the resident or the attending. It just helps highlight the balance between the patient's safety and the trainee participation in challenging operative cases, and that residents should be allowed to participate in challenging cases because there are still really good outcomes. And lastly, the study compared the complication rates for residents who started surgical training early versus late in their residency. And those who started surgical training early in their residency had decreased rates of major intraoperative complications compared to the residents who started cataract surgery late in their residency, with the complication rates for the late cohort almost 9% versus only 3% for those residents who started surgical training early in their residency. And the study just went on to say that the advantage to early surgical training for residents is that the resident can just focus on a single case at a time when the learning curve is the highest. They can gain a lot from just watching and observing the attending surgeons operate. This can help with mental rehearsal and imaginary practice. And residents who begin earlier also have more time to develop their surgical confidence and skills, allowing them to tackle those really difficult cases later in their training. So let's just briefly look at our UW specific outcomes. There was a review of almost 1,800 cases performed here at UW by 29 residents over a span of 7 years, and these were under the supervision of 3 attendings. The visual acuity for our patients was 20/40 or better in almost 90% of cases, but that improved to almost 98% of cases if you excluded patients with pre-existing eye disease. There was no increased complication rate between when comparing the younger PGY3 surgeons compared to the PGY4 surgeons, and the overall complication rates were very low, with vitreal loss being less than 2%, as well as posterior capsular tear and an infection rate very low as well. Recently, we also did a study at UW that compared resident surgeries performed manually or traditionally versus with the femtosecond laser, and compare that to attending performing cataract surgery with the femtosecond laser. And this study showed that the resident performed surgeries took longer than the attending surgeries, but there's no significant difference in the visual acuity or in complications. So again, we have great outcomes here at UW by our residents and our surgeons in training. So with that, I want to take time and let our patients talk and give their own testimony of what it's like to have a resident or surgeon in training do their surgery. And so let's go ahead and have Kevin give his perspective of what it was like having our current cornea fellow, Dr. Misha Raven, participate in his eye surgery. So Kevin, if you can unmute and say a few words.
Excuse me, I had my eye surgery back on March 4th, and then the first one was December 3rd. I had a traumatic cataracts from a fishing accident, and then my second surgery was to repair my iris and then my pupil. I dealt with Dr. Sarah Nails and Dr. Misha Raven, both incredible doctors. Can't say enough about them. This has been a horrible experience, but it's been great with the UW. I can't say enough. Everything's been perfect. My vision's coming back slowly. I do have one more procedure I know coming up in April sometime to remove some scar tissue, but everything has been just hands down amazing. Everybody I've dealt with at the UW has been great.
Thank you so much, Kevin. And, you know, it's just been such a pleasure working with you and hearing just the great story and just the great relationship you've formed with Dr. Nels and Dr. Raven. And Christiane, if you're available, if you could say a word or two as well. We'll give her a minute. Sometimes Zoom can have technical difficulties. And while she may be coming
But it
on,
won't, there you go.
oh, there we go. Perfect. Yeah, we can hear you.
Sorry, it wasn't unmuting. Yeah, I just had everything that you had just explained in your lecture done. The right eye on the 5th of February and the other left eye on the 19th. So this is pretty fresh. And you know, I was all in the whole entire time from the minute you asked me, is it okay if a resident performs this and there'll be no charge for the lenses? And sorry, it just disconnected again.
That's okay.
Anyway, can you hear me now?
Yeah, you're doing great.
Okay. And then, so anyway, everybody had, just to get to the point, everybody was, both Dr. Larson and the resident act both had a high energy of like positive energy. They explained, I'm somebody who needs explanation, and they didn't hesitate to explain a thing, and like that's what I needed, and they sensed that somehow. And now after the fact, I feel I'm just like a whole new person. I was having difficulty riding my bike. I like to ride, bike, hike, run. I'm a musician on the side. I was kind of losing my ability to read the music when I was sitting at the piano. I even noticed one crazy thing. It was easier to tie my shoes. I could see the end of my hands better to tie my shoes in the morning. So I think I'm just headed on a nice, you know, positive journey after this. But I can't say enough about how well they treated me, the caring, the explanation, the positive energy, all the supporting staff if you needed to make a call and ask a question 24/7. Everybody was understanding if I was freaking out that I didn't understand something. So, I mean, that's, and then plus the Torx lens is fabulous because I had really thick glasses and now I don't have to wear them.
Well, thank you so much, Christiane and Kevin, for sharing your experience with having residents and fellows participate in your surgery. And now let's flip the table. Let's have one of our residents speak about what it's like being the surgeon in training. So I welcome Dr. Max Wingelaar. He's our chief resident. If he could just say a few words.
Hey, good evening, everyone. Thanks for joining, and thanks, Dr. Larson, for doing this. This is an amazing opportunity. I think UW does a really good job, and especially working with Dr. Larson, of preparing us well for surgery. Everything is safe every time, and nothing is kind of candid or kind of kept under wraps from you. As the patient, we kind of tell you what's going on throughout the surgery. You're aware that a resident's participating. Nothing is kind of smoke and mirrors, which is how it should be. It's always done in a manner that takes puts the patient at the center of what we're doing. And our job here is to help you get a great outcome and protect your vision and give you the best sight possible. And you're helping us out because you're making us better surgeons, even if it's just letting us participate and getting you signed up for surgery, or helping out with one step of the surgery. It's so much appreciated. And being from a first generation college student myself, and kind of where I'm sitting now, I can't thank everyone that I've worked with enough. It's been great, and it's been an amazing experience, and I feel well prepared to take on the next steps as we head towards graduation here. So UW is an amazing place, and we get some amazing patients, and you're making us better every day. So I can't thank everyone enough.
Thank you, Dr. Wingelaar. And that was a great segue to my last slide. It's just the importance of you in our resident education. So we would not be the academic center we are without you, our patients. And if you just think of the ripple effect, the milestones that you're making by helping either in the operating room or the clinic to help the residents and the trainees learn a surgical skill or an exam skill, or just an important teaching point, and they go on to take care of thousands, hundreds of thousands of other patients, you have that direct impact into the helping those other patients. And just what a powerful thing and realization that is. And, just thank you for allowing us to train the next generation of eye doctors, and all of the people that they're someday going to take care of have you to thank for that. So the importance of you cannot be overstated. And if you're interested in giving a donation to help support our wet lab and our surgical teaching, please feel free to reach out and contact Jillian Fink. Her email address and her phone number are listed here, and we'd be happy to share that with you after the presentation again. And these are just my references for the talk. And at this time, I would like to open it up to questions.
Dr. Larson, you do have a couple questions in the chat.
Ooh, let me figure out how to get to chat. Okay.
If you end your presentation.
I would love to. Okay.
There
Perfect.
You go.
Okay, chat. Okay. Okay, let me.
David Friedman, I could just read it to you quick.
Okay. Oh yeah. So what percentage of cataract surgery is done by the UW Ophthalmology? That's a great question, David. And I don't actually have the statistic of the UW surgeries that are done by residents versus attendings here at UW. Yeah, that's a great question, because not all the surgeries done here at UW are actually assisted by residents. We can look into trying to get that number, but unfortunately I don't have that statistic. And then
one from Jenny Perry Raymond, just slightly.
So the synthetic eyes, the single use only, or do they grow and the cataract come back? Great question. So those synthetic eyes, they are typically single use only, and that's where they can be a little bit cost prohibitive, because it's typically to learn one surgical technique, and then you would have to get the new synthetic material to practice the surgical technique again. But yeah, that'd be great if they could regrow. I think you're on to something, and maybe we should have our researchers look into that, because that could definitely be marketable. Any other questions?
I have a question. How do you determine when sutures are needed?
Great question. So first, straightforward cataract surgery. Typically, we do not need to suture the wound, but if the wound is leaky, so if we touch it and we see that fluid is still coming out of the eye, then we would want to place a suture to try to make sure that the wound is watertight. But if there might be a complication at the time of surgery, then we may want to suture the wound. Or if we have to use a different type of lens, which might require a larger wound to put in, then we might also require a suture. But typically we don't need a suture. Good question. Well, I think we are at 7 o'clock. So to be respectful of everyone's time, I just want to say thank you everyone for attending our Saving Sight session. It's been a pleasure to be able to share with you. I think one of the greatest assets we have here at UW, which is our ability to teach our residents and our surgeons and trainees. So thank you. And I'm happy to stick around for questions if anyone has any others. Otherwise, feel free to go enjoy the rest of your evening. And thank you for participating.
Thank you.
Thank you, Dr. Larson.
Thank you, Jenny, Christiane, and Kevin.
Thank you, Dr.
Thanks
Larson.
again. Thank you again.
Thank you so much, Christiane. Thank you so much for talking. Thank you, Kevin, as well. Thank you so much for talking.
Bye-bye.
Bye. Thank you.